Hi there. Thank you for joining me for this 9th session of the Medical Assessment of Impairment. My name is Roger Pillemer. I'm an orthopaedic surgeon with a particular interest in impairment assessment. In the 8th presentation of the series, I discussed axillary nerve lesions and tried to point out that they were not uncommon lesions as has been suggested in the literature, but were in fact very common lesions, and that the diagnosis was simply being missed. In this talk, I would like to discuss supraclavicular nerve lesions and make the same point as in the previous talk, namely that supraclavicular nerve lesions are not uncommon as suggested, but are very common, and that the diagnosis is simply being missed. With regard to frequency, I estimate that for every 3 cases of axillary nerve lesion that I see, I will see 1 case of supraclavicular nerve lesion. As with axillary nerve lesions, the key to making the diagnosis is the finding of diminished sensation over the top of the shoulder in the distribution of the supraclavicular nerve. This slide shows the typical area of sensory loss in a supraclavicular nerve lesion extending from the base of the neck medially and over the acromion laterally, over the clavicle anteriorly and down to the spine of the scapula posteriorly. Firstly, just to revise the anatomy, and once again with the diagram taken from Netter's wonderful book on clinical anatomy, the posterior triangle of the neck is the area enclosed between the sternomastoid muscle anteriorly, the trapezius muscle posteriorly, with the base being formed by that part of the clavicle lying between these 2 muscles, generally the middle third of the bone. The floor consists of the prevertebral fascia. In this slide, you can see the 4 cutaneous nerves emerging from the posterior border of the sternomastoid muscle, which supply sensation to the skin of the side of the neck, the anterior chest wall, over the top of the shoulder to the spine of the scapula, and as far as both anterior and posterior axial lines. From superiorly to inferiorly, there are the lesser occipital nerve, the greater auricular nerve, the transverse cervical nerve, and the nerve we are concerned with, the supraclavicular nerve, which contains fibers from C3 and C4. The 3 branches of the supraclavicular nerve are variously named, and I have chosen the nomenclature of anterior, middle, and posterior branches. The anterior branches supply the skin from the sternoclavicular joint medially and over the clavicle as far down as the anterior axial line. The nerves of the lateral branch pass over the acromion to the skin over the deltoid, and the posterior branches supply the posterior aspect of the shoulder and the skin as far down as the spine of the scapula. As I will demonstrate in slides and videos, there are 2 clinical signs that will help to make the diagnosis. First and most importantly is the diminished sensation in the area described, and as with the axillary nerve, present in every case. The second sign, which I would suggest is present in 1/3 to 1/2 of cases I have seen, is a very localized area of percussion or pressure tenderness where the supraclavicular nerve emerges from the posterior border of sternomastoid. This slide shows the typical distribution of sensory loss, often not as extensive as shown here, and another case showing the same area of sensory loss and the posterior extent of that loss. I'm now going to show you 2 videos demonstrating the clinical findings, with the second case showing the localized area of tenderness to percussion. The first case is that of a 49-year-old lady who slipped and fell in a shopping centre in January 2013, falling with full force onto her outstretched arms. She was immediately aware of severe pain in her left shoulder and her left knee. At the time of consultation in August 2016, she had had 3 injections into her left shoulder, as well as an arthroscopic acromioplasty, with no improvement in her symptoms. I will let the video speak for itself. Is this sharp here?
Yes.
Tell me when it gets a bit blunt.
Blunt.
Tell me when it gets sharp again.
Sharp.
Tell me when it gets sharp again.
Sharp.
Tell me when it gets sharp again.
Sharp.
Sharp here?
Yes.
Tell me when it gets blunt.
Blunt.
Tell me when it gets sharp again.
Sharp.
Sorry, love. Sharp here? Tell me when it gets blunt.
Blunt.
Sharp here.
Yes.
Tell me when it gets blunt.
Blunt.
Okay. The second patient was aged 45 and had developed symptoms in his left shoulder in April 2014 when lifting a heavy tow chain while working underground as a miner. He was able to continue working but aggravated his symptoms in June 2014 while lifting a forklift tine into an upright position. When seen in October 2016, he had no improvement in his symptoms. Feel the pinprick here?
Yes.
All the way down?
Yes, all the way down.
Sharp. Okay, sharp there. Tell me when
Yes.
it changes.
There,
Tell me when it comes sharp again.
there,
Tell me when it comes sharp again.
there,
Tell me when it comes sharp again.
there.
Okay, so if this on this side is a 10 out of 10, how much would you say this is?
Only a 3 or something, less than half.
Less than half. Right? Now, tell me if this worries you anywhere I tap.
Just with there, right
About
there.
just there.
Yep.
Try it again. Tell me when it worries you.
There.
As with axillary nerve lesions, supraclavicular nerve lesions are not uncommon nerve lesions, but are in fact very common. I would also suggest that the diagnosis is missed simply because it is not looked for. In my opinion, the only way to make the diagnosis is to find the sensory loss in the area described. So let me ask the question that I asked at the start of the talk. When was the last time you checked for sensory loss over the top of the shoulder? As mentioned previously, and as I will emphasize in a future talk on the importance of sensory testing, if you don't think of it, you won't look for it. If you don't look for it, you will never find it. I hope this talk will encourage you to test for sensory loss in the distribution of the supraclavicular nerve in all future cases with shoulder symptoms. Once again, thank you for your attention, and I hope that you will join me for the next presentation. Until then, Salani Gashle.